So friends, our topic for the day is refractive surgeries. So basically, let's say a patient has come and he has got a -3 or -4 refractive error and he want freedom from the spectacles. So for this, a surgery that we can do is basically classified under the refractive surgeries. Now, what are the various types of refractive surgeries? These are, as you can see in this slide, radial keratotomy, microkeratome based LASIK, photorefractive keratectomies, femtosecond laser, which is used for either eye LASIK or smile. What is smile we would tell you in our further slides, and the phakic IOLs. Now, first of all, what is radial keratotomy? Earlier, when the lasers were not too much there in the prevalence, we had the surgeries which we call radial keratotomy in prevalence. So what we used to do is we used to put the deep cuts inside the cornea, okay, up to the level of stroma. We used to put deep cuts, okay. So this is basically called radial keratotomy. So a very simple procedure, radial keratotomy. What we did was we used to change the curvature of the cornea with the procedure, okay. We changed the curvature of the cornea with this procedure. What was the disadvantage was that when we used to put these scars or these cuts over the cornea, they can basically lead to sometimes astigmatism, okay. So we are correcting, let's say, myopia, and we are producing the astigmatism in the patient. The second complication which can be there in these patients is, because of these cuts, there can be lot of halos and glare to the patient, okay. So yes, being done in a very large scale in the early 90s, this surgery basically lost its relevance in the later part of 90s when there is a evaluation of laser, okay. So the radial keratotomy, the basic point that you have to remember is that we used to just make deep cuts in the cornea, and these cuts are basically used in the patients who have myopia, okay. So the radial keratotomy is done only in the cases of myopia, okay. Let's move to the next LASIK. So next was the conventional LASIK, that is the microkeratome based LASIK. So what happened was that with the progression of the science, we had this as our cornea, okay. So what we used to do is we used to make a flap in the cornea, okay. I am making it with another color. So I used to make a flap in the cornea, okay. This flap we used to make it with a blade. This blade which we use is called microkeratome, okay. This was called a microkeratome. So what we did was that we made a flap like this, okay. This flap was around 120 to 130 micrometer in thickness, and this is your stromal bed, okay. This is your cornea. After making this flap, we used to put the laser over this stromal bed, okay. The laser that we put here, what is this laser called? This laser was called excimer laser, that is the argon fluoride laser, which was called argon fluoride laser, which was called excimer laser, and the wavelength was asked sometimes, it is 193 nanometer, okay. So after doing this, what we did was that after the photoablation, we used to reposition the flap over the stromal bed, okay. So we have changed the thickness of the cornea and the curvature of the cornea, and then I have repositioned the flap over the stromal bed, okay. So this was actually the procedure of the microkeratome based LASIK, okay. So now the myopia, the surgical correction which in radial keratotomy could have been done only in the myopic patients, with the help of microkeratome based LASIK, we can use it for both myopia as well as hypermetropia. Even in the patients who have astigmatism, we can use this LASIK there also. What was the indication? That there should be a stabilization of power. Okay, so the power should not change in these cases for at least, we say, 6 months. Okay, this is a desirable criteria, that the stabilization of power should be there for at least 6 months, and we take the age which is more than 18 years as the general criteria. What are the contraindications? The contraindications of doing a LASIK surgery is that if there is a change in power. Okay, so obviously if there is a change in power continuously. Second thing is, if the patient is having inadequate corneal thickness. We would talk in detail about what is the inadequate corneal thickness and how it can be tackled in my further slides, but at this point just remember, if it is inadequate corneal thickness, this is also a contraindication. Then if the patient is having pregnancy, patient is having any corneal opacity, or if the patient is having any active viral keratitis, okay, or if the patient is having any retinal pathology which is untreated, okay, any retinal pathology untreated, or the patient is having active glaucoma, so these were considered as contraindications of LASIK surgery. So what is the investigation you do? You basically, in these cases, you have to see the corneal thickness. Very important is corneal thickness. The second thing that you have to see is that you have to see the patient, what is the curvature of cornea. So I write it, corneal curvature. Third thing which is important in these cases is how much is corneal diameter. Then in these cases you have to screen the anterior chamber and the anterior segment, plus if there is any pathology in the posterior segment. So all of these has to be done before a LASIK is done. A very important instrument which can basically take care of all the corneal investigations like corneal thickness, corneal curvature, corneal diameter is called pentacam. Okay, so if they ask the investigation of choice for any corneal ectatic disorder or LASIK, your answer is pentacam. Okay, now what is the basic meaning of residual stromal based thickness? So RSBT, which we call, basically the cornea is 520 micrometer. Okay, so we say at around 520 to 540 micrometer is the normal corneal thickness. Whenever I make a flap, I told you in microkeratom I make a flap. This flap, let's say, is 100 to 130 micrometer. Okay, so this cornea which is left would be, if let's say this is a 520 micrometer, the cornea that is left is 390 micrometer. Okay, now for if this patient is having a -5 diopter refractive error, okay, if the patient is having a -5 diopter refractive error, the patient is -5 diopter myopic, so what I would do is I would do ablation with the excimer laser. So let's say with the excimer laser ablation, for every diopter I am basically ablating 10 micrometer thickness of the cornea. So how much it would be finally? It would be -50 micrometer. Okay, I'm just giving you an example. So what is my residual stromal bed thickness here? Okay, so it is residual stromal bed or residual stromal base thickness here. It would be your 520 minus 100 minus how much? 50. Okay, so how much that is left? So 520 minus 150, so that would be 270 micrometer. Okay, So that is how you can calculate a residual stromal bed thickness. Now if this residual stromal bed thickness is less than 250 micrometer, so this is a contraindication for doing a LASIK. Okay, so that's why we say that the patients who have very high myopia or who have very thin cornea, okay, so these are the two factors which are basically are depending upon how much is the corneal thickness. Okay, so if the RSBT is less than 250 micrometer, okay, why it can be? Because if either there is a thin cornea or there is a high refractive error, you cannot do a LASIK surgery in these patients. Okay, so this is called RSBT or residual stromal bed thickness. Post-operative follow-up, you tell the patient that the surgery is over and you get spectacular results in the first hour of the surgery, but you give a steroid antibiotic eye drop for a few days, let's say for 3 weeks, and you also tell the patient that you have to use the lubricant eye drops for a month or so because you have made a cut inside the cornea. Okay, so usually I give it for 3 weeks and then we see the patient again. If he needs, we can continue, otherwise we can stop these medications. Coming to the complications, most of the students ask me, sir, is there any side effect or any complication of the surgery? So this is very rare, and the most common complication of the LASIK surgery is if the patient gets the refractive error again. The next very important complication can be the dry eyes. What we have seen is that after we do a LASIK surgery and whenever we use a microkeratotomy blade, there are some nerves which this blade can cut, and this basically can cause a dry eye. So basically to treat this dry eye, what we do is we can give lubricants like polyethylene glycol, like sodium hyaluronate to the patient so that he gets symptomatic relief. The next very important complication of a refractive surgery like microkeratotomy based LASIK is the corneal ectasias. So what do you mean by corneal ectasia? So it is like a keratoconus. Let's say you do a refractive surgery and after that the corneal thickness that is left is around 240. So this is a thin cornea left after a refractive surgery. So there would be a pressure that is coming from inside of the eyeball. So what this does is it can basically cause an ectatic cornea. Okay, this is called corneal ectasia. And why this corneal ectasia is important is this: first thing is because it is thin, it can lead to your perforation. Second thing is the patient would say that, sir, I have got again a refractive error. Okay, because your corneal curvature has again changed. Okay, so this corneal ectasia is a very dreaded complication which can be there in thinner corneas. Then sometimes there can be a diffuse lamellar keratitis. So whenever we make flap and then we reposit the flap, there can be a inflammation there, so that we call it diffuse lamellar keratitis. Last but not the least, we can have infection by the atypical mycobacteria. Okay, so remember, atypical mycobacteria are most common cause of the infection in post LASIK patients. Okay, so sometimes if there is a patient who has a thinner cornea, okay, so the patient who is having a thinner cornea or the patient who is having a high refractive error, you cannot do a microkeratotomy based LASIK in these patients. So what is the option? The option then comes the photorefractive keratectomy. So what we do here is we do not make a flap. Let's say this is your cornea, and here with a blade or with just a laser, I can remove the epithelium. Okay, so I just remove the epithelium, and after removing the epithelium, I put the laser directly on this bed. Okay, I put the laser directly to this bed. So what is the basic advantage is that the flap, which is what you say is around 100 to 130 micrometer, that thickness is basically preserved in this photorefractive keratectomy. But because this epithelium is a very sensitive structure, so patient says that after surgery, sir, I am getting a lot of pain. So to avoid pain, what you can do is you can put a bandage contact lens here. Okay, and this bandage contact lens which we have put here, then beneath it there can be a regrowth of epithelium. So this is basically called photorefractive keratectomy, basically done in the patients who have thinner corneas or high refractive errors. Then the next type of LASIK is the eye LASIK, which uses the femtolaser. Okay, so what happens in femtolaser is we basically do a femtolaser assisted LASIK, where the flap that we made, this flap we usually make with the microkeratom based LASIK, but in these patients the flap is made by the 1053 nanometer femtolaser, and this 1053 nanometer, this is more predictable, okay, as compared to your blade based LASIK. This is more predictable and more homogeneous flap. So the chances of buttonholing of the flap or irregular flap, that is much less in a femtolaser assisted surgery as compared to a microkeratom based surgery. So that's why a surgery which uses femtolaser, this is also called bladeless LASIK. Okay, I also call it bladeless LASIK. Then the last but not the least type of refractive surgery is small incision lenticular extraction. So in this case what we do is that, let's say this is the cornea. So remember, one thing very important is that in small incision lenticular extraction, this can be done only in the cases for myopia or astigmatism. Okay, it cannot be done for your hypermetropia. Remember, the femtolaser can be done for the hypermetropic patients also. So what happens in small incision lenticular extraction? With the help of femtolaser, we make a lenticule inside the cornea. Okay, a part of cornea we basically separate with the help of femtolaser. Okay, the same laser which we use in the eye LASIK, and then from outside I basically remove this lenticule. Okay, I remove this lenticule. This is called small incision lenticular extraction, or I also call it smile surgery. So because there is no blade used here, and this patient is called, this type of surgery is called bladeless, and because there is no flap created here, this is also called flapless. So this is a bladeless and flapless LASIK which we do nowadays in the patients of high myopia. Now there can be a condition where there cannot be a smile that can be done, there cannot be any eye LASIK can be done. So in that cases where we have very high refractive errors, so let's say we have a high refractive errors of the terms of -20, -25, -18. So in these very high refractive errors, you cannot basically ablate the cornea, because as soon as you ablate the cornea, maybe let's say -20 you are ablating, so -200 is the ablation depth which you do with the help of your laser also. So you are making the thin cornea by -200 just by the laser, so that is not practically possible. So in that cases we do a surgery which is called phakic IOLs. So what I do in phakic IOLs is that, let's say this is the cornea, this is your iris, okay, and this is my lens. So what I do is I put a small intraocular lens between the iris, okay, between the iris and the lens. Okay, this is called phakic IOL. Okay, so remember, phakic IOLs are done in the patients who have high refractive errors, which are unsuitable for doing any type of laser assisted surgery. Okay, so these are the various type of refractive surgeries that you have to remember for your exam. All the best.